Welcome everybody to the webinar, which is being done by the NIHR Policy Research Unit in Older People and Frailty, now the Policy Research Unit in Healthy Aging Policy Research Unit. This is one of a series of these webinars that we've been running. So if you haven't been to any of the ones before, or you want to come to the future ones, please make sure that you get information which we'll put up at the end of future. Today, we'll be looking at the digitalisation of health and social care services for older people and learning from the COVID-19 pandemic in particular. We have 3 presentations and there'll be an opportunity for question and answer after each of the presentations. Now then, let's have a little bit of housekeeping here. If you look at your screen, you should be able to see a Q&A button. For those of you on iPads or phones, you might have to look along where the dots for extra information is, but you should be able to find Q&A. And if you click on the Q&A, you will be able to ask questions, which we will then moderate for each speaker. If you can't access Q&A, and we know that some of the firewalls, NHS firewalls, do seem to make that problematic, just use the ordinary chat and we'll try and make sure that all questions get a look at in. Also, you can vote for questions. If you see a question that somebody else has asked that you think is particularly pertinent, please just sort of put your thumb up against it to indicate that you'd like that question asked. Throughout the webinar, we will be posting links to information that arises from the talks. For example, the publications that are mentioned. I should mention a couple of these talks are actually pre-report to the Department of Health and Social Care, so are not fully in the public domain yet, but will become so in the near future. Right. What else is there to say? I think that's all my notes. So if I hand over to Alex Hall, who's going to be our first speaker, and he will then be introducing the topics overall. So, Alex, are you ready? Is that okay?
Yeah, thank you, Chris. Okay, yeah, thanks very much, Chris. Good afternoon, everybody. So my name's Alex Hall, and together with Nisar and Abadunrin, we are going to present a summary of a programme of work exploring the impact of digitalisation of health services for older adults since the start of the COVID-19 pandemic. This first presentation, which I'm going to do, is about the initial piece of work we conducted in order to map the evidence landscape about digitalisation of health and care services for older people since the onset of the pandemic. So, although there are 3 of us presenting today, just want to acknowledge that there are a lot of people who've been involved in or who have supported this work, including researchers across the Policy Research Unit and also various community groups and organisations that we have worked with. So, digital health is clearly not new. You may know that the World Health Organization has a current strategy on digital health that has been developed over the past 2 decades. And this quote here is the opening lines of this strategy document. And I've highlighted some key emphasis in bold here at the bottom of the quote about the need to promote equitable, affordable and universal access to the benefits of digital technologies for health. As many of you will know, here in the UK, use of digital technologies is a key component of recent and current health policy, including in the NHS long-term plan. It's part of a post-COVID recovery plan to improve access to primary care. And there's a lot of emphasis on use of the NHS app as the front door to the health service. But although there are many potential benefits to digital approaches, there are concerns that some people or groups in society may be excluded by digital by default approaches. Digital exclusion may be broadly defined as lacking access to benefits offered by digital technologies in everyday life. And these 3 aspects here, affordability, access and ability, are commonly cited as reasons for digital exclusion. So people may be digitally excluded if they cannot afford digital devices or internet access or data, if they are unable to connect to or access the internet because of poor infrastructure. But even if people have no financial or infrastructural reasons why they might be excluded, they also need to have sufficient skills and knowledge about how to use digital technology, and also the confidence and the motivation to do so. Digital exclusion is influenced by a really complex interplay of personal factors. So although in general, older people are the least likely to access and use the internet or to own devices like smartphones, digital exclusion is much more complicated than age alone, as there are all these other factors involved, including things like your income or socioeconomic status, where you live, your education and literacy levels, etc. There's been a great deal of work going on around digital inclusion and exclusion, as many of you will know, from a whole range of organisations. Here are just a select few examples. So the NHS has a digital inclusion guide. Ofcom and the House of Lords Committee have recently investigated and produced reports on digital exclusion. Age UK has a policy position. And the Good Things Foundation, which is a major organisation working to make digital more accessible, has a current strategy to fix the digital divide across society. And here in our region, in Manchester, the Good Things Foundation has worked with the Greater Manchester Combined Authority to produce this practical guide to doing digital in later life for older people. So as a policy research unit, we have been interested in the implications of digital health for older people for a long time. So in 2019, pre-COVID, of course, we carried out a high-level review of reviews of evidence about whether digital technologies enhance older people's access to health and care services. And overall, we found that there was no review-level evidence on whether technologies really improved older people's access to these services. And overall, this review-level evidence was limited in scope and quality. This review is available on our website. As I said, it was published a few years ago now. So then COVID happened, which increased the rollout of digital technologies in lots of areas of society, including health and care services. We wanted to continue our work to see what changed during COVID and what the impacts had been for older people. So we first conducted a review to map the evidence that's conducted since the start of the pandemic relating to digitalised health and care and its impact on older adults, which I'm going to summarise shortly. So we did the main searches for this evidence in March 2022. So we were focusing on a time frame of about 2 years. We then carried out some qualitative research, exploring the experiences of older people from minoritised ethnic groups, which NIHR will talk about next. And we're currently conducting some quantitative work, looking at trends in general practice consultation rates, according to whether they're face-to-face or remote, which Aberdunren will describe in the final presentation. So in our review, we wanted to map the evidence available or being sought on pandemic-related changes in practice and switches to digital ways of working. We wanted to know which service areas and technologies have been explored, key detail about research studies and where they've been carried out, and to identify the extent to which factors relating to health inequities have been investigated. So in this kind of review, we're mapping the landscape. It's a high-level review where we're looking at what has been done rather than looking in depth at the specific findings of individual research studies. So we adopted a systematic approach to this review, which is common in academic research to provide a robust review of published research. We searched 3 academic databases for peer-reviewed literature from anywhere in the world. And in the UK, we also searched for what's known as grey literature. So these are reports of research published by organisations that are not subject to academic peer review. So we looked at websites of third sector organisations and major research funders. I mean, any systematic approach to reviewing evidence, you need to set out key criteria to help you determine which studies you are going to include. So we were looking for studies that must clearly identify people over the age of 65. We were interested in any form of digitalised intervention or change in practice that had been implemented since the start of the pandemic. And we were interested in community settings, so we excluded work that was exclusively set in hospitals. We were also interested in any outcomes, including clinical outcomes, reports of service use, and people's experiences of using digitalised services. So as we were applying an equity lens, we used a framework called Progress Plus, which helps us to look at how far factors relating to equity had been considered. So as you can see, Progress Plus is an acronym for these various factors that can affect health outcomes. And we use specialist software called EpiMapper to produce evidence maps. So here's a quick example of what the evidence maps look like. I'm not expecting you to read this in detail, but the point to highlight is that they allow us to map clusters of evidence and where the gaps are. So this map has the health and care services across the top, and the technologies down the left. And the top left cell in the matrix with different size circles, these indicate different types of evidence relating to telephone access in the context of GPs and primary care. So the full versions of these maps are interactive. So when we click on the cells, we can see details about the individual studies. And there are links to the interactive versions of these maps within our summary report that's available on our website. So I'll just summarise some of the headline findings from the mapping review. So overall, we included 171 studies internationally from 24 countries. 2/3 of the studies were from North America, and there were 23 in the UK. When we ran a UK-only update a year later in March 2023, we only found another 3 pieces of work. So this shows that most of the work was conducted towards the beginning of the pandemic period. One example finding is around the technologies contained within the studies. So this graph here shows the UK studies in blue and the global studies other than the UK in green. I'm sorry the writing's so small on these axes. This is taken from the full report. The point to highlight here is that a lot of studies had looked at telephone use, but the extent to which this referred to digital smartphone use or just standard telephone was not always clear in the literature. If you're wondering why we're looking at telephones, even standard telephones, which may not be digital technologies, remember that all landlines in the UK will have gone digital in the next year or so. So it's important to include telephones under this umbrella of digital technologies moving forward. There was also quite a bit of work looking at video consultations in the second pair of columns there that you can see, and much less work looking at other types of technologies such as apps. So when we look at the kinds of outcomes that have been investigated in the research, there's some difference between the UK literature compared to that of other countries. So around half of the UK literature was qualitative, looking at people's experiences of using technologies, whereas the international literature was more focused on quantitative analysis of service use, and this particularly came from the North American work. When we apply the Progress Plus equity lens framework, we can see a lack of focus on factors relating to equity. So this table is about the UK studies only to exemplify this. So we first looked at which studies had recorded any information about any of these characteristics among the study participants. So all of the studies had included detail about age at the bottom there. But of course, that was because that was one of our inclusion criteria, that participants must be at least 65, so age had to be specified. But if you look at the other factors, you can see that not that many studies had recorded information about these other characteristics. And what's more interesting is that even fewer had actually done anything analytical with the information that they collected. So it's one thing to describe participant characteristics, but it's another thing to then offer some kind of analysis or interpretation about what this means in the context of the study findings. As the studies were often small or set in one health service, this is perhaps not surprising, but it shows a key point that we were really interested in, which is that there's been a lack of focus on equity factors in this work, and therefore the concerns about the implications around digital exclusion that I mentioned earlier, the implications for the concerns around digital exclusion that I mentioned earlier are likely to be limited. So in March 2023 update of the UK studies, we went slightly beyond mapping the evidence to look a bit more closely at the actual findings within the studies. The most robust work was in the form of 2 studies that had looked at GP consultations. And in general, these data showed that in-person appointments had been maintained for certain groups of older people who would appear to be most likely to benefit from or need in-person appointments. The survey and qualitative work investigating people's experiences was mainly positive, but there were cautions that one size does not fit all. This is a theme that we'll return to in NIHR's presentation. And there are certain reasons why digital or remote consultations may not be appropriate. So this might depend on the type of consultation or reason for appointment, may depend on the importance of verbal cues or body language for certain patient groups, etc. And people had concerns around things like privacy and data protection. A key limitation is that most of the work looked at data collected in the first few months of the pandemic. So overall, it seems that there's been an initial research response in this area about the impact of the pandemic and digitalisation. But of course, this was when we were still in lockdowns and social restrictions. So a longer and more nuanced lens is needed to look at the implications of digitalisation on service access use and experiences. So I'll end there, and as we said, we're happy to take some questions now. Otherwise, I will hand over to Nisar to talk about the qualitative work with older adults from minoritised ethnic groups. Thank you.
Thanks very much, Alex. Now then, I've been keeping my eye on the chat and on the Q&A function, and nobody's asked you any questions at this point. So rather than making up some questions, I think what we'll do is move on to Nisar's presentation, but people can continue to put questions in, and maybe it'd be easier to take the questions as a bulk towards the end of the webinar. So please do put questions in or use the chat function to ask questions either about Alex or any of the other presentations. But now let's move on to Nisar Ahmed, who is going to tell us about some qualitative work we did. And I should have said at the beginning that this is work which is, while we've got specific presenters, has involved quite a number of members of the Policy Research Unit in conducting both the reviews and the qualitative and quantitative work that we're presenting. So over to you now, Nisar, to talk about the experiences and views of older people from South Asian and Black African and Caribbean backgrounds. Thank you.
Thank you, Chris. Good afternoon, everyone. Thank you for joining the webinar today. My name is Nisar Ahmed. I'm a research fellow at the Policy Research Unit at the Healthy Aging Group at the University of Manchester. And thank you to Alex for providing an overview of the programme of work that we're currently undertaking. I'll be presenting a qualitative study looking at the experiences and views of older adults of South Asian background and Black African or Caribbean background about the digitalisation of primary care services since the COVID-19 pandemic. So primary care services include general practices, pharmacies, dentists, optician services. So the research aims were to explore experiences, so issues around accessibility, perceptions and expectations of older adults who were 65 years or older in the use of digitalised primary care services since the beginning of the pandemic. The study focus was on participants from the South Asian backgrounds and Black African or Caribbean backgrounds. These groups were chosen as they represent the largest minority ethnic groups in England and Wales. So the summary of qualitative focus group study is looking at the views that were obtained from face-to-face and online focus groups that were undertaken in April and May 2023. So briefly, the methods: we recruited 27 people who took part in four focus groups. These were held in person or online using Zoom. So the aim was to recruit both digitally included and digitally excluded participants. Patient and public participation engagement was sought using two approaches. That was through participatory approach with community organisations in Greater Manchester for recruitment and arrangement of focus groups, and through feedback on focus group topic guide, which our research team developed. In terms of the data analysis, focus groups were digitally recorded and transcribed. They were analysed using the framework analysis approach, which was considered to be sufficiently rigorous for the purposes of this study. Ethics approval was granted by the University of Manchester Research Ethics Committee, and we obtained written informed consent prior to taking part from the participants. Just an overview of the table 1 shows the characteristics and distribution across the focus groups. So as I've mentioned, 27 participants, 22 out of these 27 were female participants and only 5 were male. The South Asian groups, the participants were mainly from the British Indian Gujarati community, and for the Black or African Caribbean groups, we had an even split between Black African or Black Caribbean participants. So the findings, these are organized around 4 themes. Theme 1 looked at the accessibility to healthcare services. So here we explored perceptions of online or remote health service accessibility and the impact of language barriers. Theme 2 looked at the importance of face-to-face or in-person contact with clinicians. So here we highlighted situations where face-to-face interactions with healthcare professionals were considered important. Theme 3 looked at the stresses caused by the shift to remote access, so looking at the psychosocial impacts for participants attempting to access health services remotely. And finally, Theme 4 looked at digital solutions, which evaluated technology acceptance, so the extent to which participants view increasing digital technology as acceptable and appropriate. So briefly, Theme 1 looked at accessibility. We found that many participants face challenges with online and remote health service access. Particularly, they were experiencing difficulty securing GP appointments, leading to early morning calls, the so-called 8 a.m. rush. There was a perception that receptionists were acting as gatekeepers, asking what were considered by participants as personal, sensitive, or inappropriate questions and reasons for wanting an appointment. In terms of language difficulties, there were language challenges which appeared to hinder remote health service access, particularly with non-English speakers, and this was more prominent in the South Asian communities. Participants experienced difficulty using online methods for making appointments or health information, and were finding it challenging to verbally communicate medical symptoms, issues, concerns, or problems over a telephone conversation. Participants also suggested that we provide information and interactive services in various languages. However, there were concerns about poor first language literacy, with some older individuals recognizing that this may not suit everyone. For example, some South Asian people had difficulty reading and writing in their own languages. There was also a perception of bias that the current online systems and technology favor predominantly white or English proficient individuals, and there was particularly concerns about the lack of consultation during development stages of developing digital health technologies. Some participants felt that digital access to healthcare, in their words, was thrown at them. Because of this rapid implementation and adoption, it's likely to take time for them to adjust to this new way of working. There was extensive discussions around the perceived lack of digital skills among older people in their communities. Here, the role and importance of younger relatives and community organizations in digitally supporting older individuals was highlighted, particularly during the pandemic. However, there were concerns raised about the appropriateness of such support in healthcare contexts, especially regarding privacy. For example, as seen in gynecological appointments where women are discussing sexual health or other mental health issues for women. And again, this was particularly prominent in the South Asian group. Theme 2 looked at the importance of face-to-face or in-person contact with clinicians. There was a strong preference expressed for in-person appointments, highlighting challenges, for example, understanding problems without visual cues, and there was value placed on face-to-face consultations for interpersonal connectiveness with GPs, which was described as uplifting and healing. Some participants believe that face-to-face communication is more effective in explaining problems, particularly for individuals that face language challenges and difficulties. In terms of views on video consultations, here participants indicated limited experience or exposure to video consultations with GPs, but some participants view them as positively. Those that did have experience perceived this to be the next best thing to in-person appointments because of the familiarity that they gained from remote interactions, particularly during pandemic when a lot of people use Zoom to communicate with family and friends. In terms of the stresses caused by the shift to remote access, high on the list is fear and anxiety. So the fear associated with utilizing digital health technology for health appointments causes stress, agitation, frustration, and elevated anxiety levels. These encounters and experiences contribute to increased fear of falling ill. There were concerns around digital access, some participants finding this sudden introduction of digital access to healthcare challenging and believe it will require time for adjustment. Concerns include issues with consent, so understanding the small print and confusion regarding data handling during engagement with digital health services. There was fear and confusion surrounding technology use, which extends to broader areas such as experiences with online banking and scams. In terms of institutional racism concerns, participants from the Black, African or Caribbean groups voiced concerns about institutional racism and discrimination in the health service. There were feelings of being treated differently based on racial identity, affecting both phone and in-person interactions. And there were instances noted where there was perceived lack of sympathy, empathy or respect when making appointments. In terms of cultural gender differences, there were reflections on these, emphasizing potential for further exclusion of digitally excluded Asian men due to their reluctance to seek healthcare. However, it's important to acknowledge that most individuals that participated in this study were women. Finally, theme 4 looked at the acceptance of digital technology. Participants recognized that at some point, inevitably, they would have to use digital access in order to access health services. However, they caution against perceiving digitalization as a complete solution, and there's an acknowledgement that one size fits all is not suitable and there is a need for offline alternatives. The importance of choice is highlighted, where we need to offer individuals choices in consultation methods, and then the concept of hybrid approach, where you combine both digital and non-digital options. There was some participants that voiced doubts and expressed skepticism about the potential benefits of technology-based health services, particularly in relation to concerns about the effectiveness of such services in the absence of an adequate clinical workforce to deliver this care. Finally, the implications in terms of inclusive design. The design of digital health services should incorporate thorough consultation and user experience research with older adults from diverse backgrounds. These include adults with limited proficiency in English language. And we must acknowledge the influence of language barriers on digital literacy and engagement, and must not underestimate these challenges. Providing translation functions alone with digital technology may prove inadequate because of the poor first language literacy among some individuals. In terms of privacy considerations, we must acknowledge that there's instances where seeking assistance from family or friends to use digital technologies may not be suitable, as I've mentioned, particularly when dealing with personal or intimate health issues. In terms of communication preferences, face-to-face or visual contact with clinicians is vital for patient confidence, understanding and establishing a therapeutic relationship, particularly for older adults, as I've mentioned, with limited English language skills. Video technology is deemed as an acceptable substitute for in-person consultations, especially for specific health issues, as I've mentioned, mental health and reproductive health or sexual health issues. And it's important to maintain choice and options in how people access health services, both digital and in-person and our offline options. And policymakers should consider and evaluate the use of buddies or digital health champions, which have worked quite well when they have been used in Greater Manchester in the past. These should be at practice level to support individuals that are facing or experiencing difficulties with accessing services, so provide them with training opportunities. The strengths and limitations the strengths are obviously the sample size is 27, and we use a participatory approach for in-person focus groups. There was extensive engagement with 2 community organisations in Greater Manchester who supported the recruitment of diverse group of older people from different minority groups, and 5 of the 27 participants were aged at least 75. This addresses a gap in research that's often lacking in people over 75, especially in studies related to digital technologies. So briefly, the summary, the limitations are the digital exclusion representation. Despite our participatory approach, we acknowledge that the study may not have fully captured the experiences of older adults from ethnic minority groups who are most digitally excluded. We did aim to recruit participants across the digital engagement spectrum. However, the qualitative data suggests that the levels of engagement appear to be similar across the in-person and online groups, and all participants had a good level of English, limiting insights into dual challenges of digital and language exclusion during attempts to access health services. And of course, there was a gender imbalance. Majority of our participants were women, which limits the insights into gender-based norms and expectations within each ethnic groups. So finally, acknowledgements. Many individuals, including researchers within our Policy Research Unit and various community groups and organisations have helped or supported this work, and we're very grateful for their input and support. So we'd like to thank all participants, particularly the 2 community groups who played a significant role in recruitment and providing venues for conducting the focus groups. These were the Caribbean and African Health Network and the Gujarati community group, Deepak Dristi, which is also known as Light of Vision. In terms of dissemination, we are planning a much wider dissemination of the findings. A report has been submitted to the Department of Health and Social Care, and a manuscript has been submitted to the Journal of Medical Internet Research in Aging, which is currently under review. So finally, thank you. And if you've got any further questions, please feel free to reach out to us in the chat or email below. Thank you very much for your time.
Thank you very much, Nissa. Now then, we have got a question in the chat, and I'll apologise to one of the people earlier on. I didn't pick up on your question to Alex earlier on, but we'll come back to that if you don't mind afterwards. Who designed this system? Because chat scrolls one way, question and answer scroll the other way, so I missed questions. So actually, there's a question for you, Nissa, about how would you envisage champions working in practice at a practice level? Would they be practice staff, or would they be wider organisations?
Yeah, I think there was some talk within the focus groups of some initiatives within Greater Manchester where sort of digital health champions came in, provided training to older people on how to use the IT equipment, the computers. But the feedback was that after a while, they didn't actually come back, and they didn't see anyone after a short period of time. I think, but they found that within community organisations, it's important to have training sessions, particularly within general practices where individuals who have limited sort of IT skills or not computer literate can go in and obtain that training. I think many individuals or participants found they were able to use Zoom when a lot of sort of community members from these different communities went out to their homes and helped them set up these systems. So I think that was helpful. So something similar that could be sort of replicated within general practices or within these community organisations would be particularly useful.
And another question that's been asked is, did you ask your participants about their work lives and their experience of technology in the work life? Because the suggestion is that if you'd worked with computers, presumably before, you might be more used to doing this sort of online stuff. Yes,
that was one of the questions, and I think there were some individuals who said that despite being computer literate, they did experience some challenges when sort of logging onto these online platforms. And yeah, so they did, I mean, despite being computer literate, they did experience some of these challenges, but as time went on, I think they became more sort of able to use the online technologies as many people.
I'm going to abuse chairman's privilege and ask you a question as well. You've mentioned the issues around older people's literacy in their original languages. So this isn't, and of course the problems of certain sorts of consultations needing somebody to be there with you to do the translation. But that, of course, is not just an issue for online, is it? It's an issue that we see pervasive within the healthcare system.
I think it's it's widespread. I mean, having spoken to some sort of community workers, they sort of organize sort of community groups and training sessions, and they did mention that many people come in with their sort of mobile phones and apps, and they're unable to even use these devices, and of course they have poor literacy in some of them in their own sort of language, so they do experience some of these challenges. And some of these community organizations do run training sessions where they're helping these individuals become more sort of efficient in using some of these devices in an online system. So a lot of help they are getting from these community organizations, and quite surprised to see the help that this is being provided, particularly with the organizations that we work with.
Thanks very much, Nisal. Very interesting. So I think it's time to turn to the third of our trio of talks today, and to introduce Abadan Imanu, who's going to be speaking on behalf of the group who've done some quantitative work around digitalisation of GP consultations. So Abadan, if I hand over to you.
Thank you, Chris, and thank you everyone for joining. My name is Abadan Aminu, a research associate in the Older People and Frailty Research Unit here in Manchester. And as mentioned by Alex earlier, this will be the third part of the presentation. I also want to acknowledge everyone who's contributed towards this project. This is a continuation, of course, of our project on digitalization of health and social care, with specific analysis of inequalities in GP consultations over the pandemic via a research platform called Open Safely. The COVID pandemic came with lots of experiences, and one of those is the shift in the use of digital services in primary healthcare. There were public restrictions during the pandemic to curb the spread of the virus, which later led to the disruption of GP services, including face-to-face appointments. In response to this, there was an increase in uptake of technologies in GP services over the pandemic. Historically, the switch to digital services has been one of the NHS England's policy for improving access to primary care. However, the transition to services, these digital services, is a concern for excluding access for some older people. So in our analysis, we have investigated digital access to primary care, which we refer to as remote consultation later on in the presentation. Primary care appointments, which are not held in person, rely on a range of digital services, which includes video and telephone calls. So our research objectives were to examine how the use of these technologies changed over time in terms of remote consultation, and to assess rather the impact of health inequalities on remote consultation patterns. So we have used a platform called Open Safely, just to mention that this actually is a feasibility study to examine the potential of using this platform for analyzing changes in remote consultation. The Open Safely is a secured research environment that provides the platform for accessing electronic health records. It is a collaboration between many institutions, including the Bennett Institute for Applied Data Science at the University of Oxford. Also in collaboration with TPP and EMIS, which is the Phoenix partnership in charge of System 1 used by the GP practices, and EMIS as well, and other health electronic record software companies. So we analyze data from this platform. So they provide, in short, access to data from different electronic health records. So we access this through this platform and we analyzed data from individuals who were aged 18 years and over, corresponding to estimated 19 million records. All the data were collated, stored, and examined securely within the confines of OpenSafely platform. And the focal point for us was the first national lockdown day in the UK, which was the 23rd of March. So this day serves as the reference point for us, distinguishing between the pre-pandemic period, which is between March 2019 to March 2020, and then the pandemic period, which was March 2020 to 21, and then March 2021 to 22. So we had 2 pandemic years in our analysis. So we conducted some trends analysis to look at how remote consultations have changed over the years, and we also looked at total appointments in our trends analysis, and then we also conducted regression analysis to determine variations in both remote consultations and total appointments. For the regression analysis, odds ratio here, the odds ratio actually is a measure of relative differences to the reference group, and here it simply refers to how strongly the rate of remote consultation is associated with some of the variables of interest. Anything above 1 shows higher likelihood of the outcome, in this case, which was rate of remote consultation, and below 1 shows lesser likelihood. And our variables of interest were age. We had 5 age categories in our analysis: gender, deprivation, and ethnicity. And the deprivation variable were actually the index of multiple deprivation, which range from IMD1, which is most deprived, and to IMD5, which is the least deprived. This is a snippet of our summary table showing total number of remote consultation and appointments for the different age groups. There was about 200% increase in the remote consultation across the study period, as can be seen here, which approximately 80% of which were telephone calls. Although total appointments dropped as well, as you can see in the first year of the pandemic, but it also kind of increased more than the pre-pandemic period in the second year of the pandemic. Excuse me. So this is a plot showing the monthly crude numbers of remote consultation pre-pandemic and during the pandemic. And this is the reference point that I mentioned earlier, which was March 2020. So this area was the pre-pandemic area, and then this is the first pandemic area and the second pandemic period. As you can see, there has been an increase in the total number of remote consultations that can be seen right from March 2020, coinciding with the period of the first national lockdown for all age groups, but most especially in the age groups 18 to 49. In the next few slides, I will show numbers of remote consultation out of the total appointments. So we also looked at the proportion of remote consultation out of the total appointments in each month of the study period as a proportion. And the plot of monthly proportion of remote consultation to the total appointment by age group. Interestingly, we can see that pre-pandemic, the age group 85 plus had the highest odds of remote consultation pre-pandemic, but this later changed during the pandemic. In the top right corner here are the odds ratio from our regression analysis, showing significant association with age. This here is a plot which we have actually used to validate our methods and results by comparing what we have done in OpenSafely to publicly available data from NHS Digital. So NHS Digital also published their data about being aggregated yearly. So we went back to look at what they published and see whether or not there is a similarity in what we are seeing from the OpenSafely platform and what they have published. So here we can see that they provided similar pattern to our findings. Some of the things that we can also observe from their findings are regular dips here around October of each year. And on a further check, we realized this was not really a reduction in remote consultation, as you would see in our own graphs as well, our own plots as well, but possibly seasonal increase in face-to-face appointments. Here, we could see that men consulted less than women, which is actually consistent with previous research. Again, the odds ratio from our regression analysis show that there is a significant association. And there was also a variation across different ethnic groups. And also, we looked at how this changes by deprivation, which I mentioned earlier. The deprivation IMD1 being the most deprived and IMD5 being the least deprived. Although we didn't look at how different technologies varied over the pandemic, as this is a feasibility study, our analysis have shown increased use of remote consultation during the pandemic. There was also an increase in the total number of appointments. Digital appointments may present as a technological barrier to some, but we believe that they may also have contributed to a greater number of appointments overall, possibly reducing barriers to primary care. The statistical significance from our analysis warrants further investigation to understand these variations among the different patient groups. For the strengths and limitation, the strengths actually comes from the study design mainly and the use of Open Safely platform, including access to large electronic health records and a secured research environment. But of course, we also noted that there were some limitations. One of it is this non-conventional way of using data in health research that Open Safely presents. So it actually was a steep learning curve adapting to how to use Open Safely for health research. Also, we had some challenges around having inadequate metadata, which really we feel it's actually not knowing what clearly triggers appointment data to be recorded in TPP. As with most routinely collected data as well, the primary goal of the electronic medical record is not research. So we believe that data entry by GPs may be subject to selection effects. Some changes may reflect differences in recording practice rather than changes in clinical practice. And that would be the end of the presentation. Thank you for listening. I'm happy to take your questions. And you can also reach out through the contact on display for more inquiries. The report for this project is still being written and will be available in our portal as soon as possible. Thank you.
Thank you very much, Abadunran. So, as you can see, quite a sizable piece of work, 19 million odd people taken part in it. And I would like to just reassure everyone that the Open Safely system is all anonymized and is very secure in the way it's set up, so that it makes it very difficult, in fact impossible, to identify who those 19 million people were or who any of those people were who were doing remote consultations. I haven't got any questions in the chat for you, Abadunran, but I know that you pointed to the dips in, oh hang on, somebody put something in. Yeah. Yes, somebody's asking about the link with deprivation, and would they be correct in saying that from the chart that the people in the most deprived quintile could access remote consultations?
Yes, absolutely. That was spot on. We believe that, yeah, that was the case. We so believe that there might be a need for further investigation to examine this further. But one of those plausible explanation for that might be because those in the more affluent area might have been able to have access to more face-to-face appointments. and as a result, they might not have used more of remote consultation compared to those in the more deprived area. But yes, that was what we kind of have seen from our analysis.
That's correct, isn't it? The odds ratios were all very close to 1, not very far from 1, but actually the confidence intervals don't overlap 1, so they did actually differ. So whilst not strong that it is there, I'm cheating because I've managed to just pull up the odds ratios on another screen rather than necessarily remembering it all. I was also going to ask if you'd like to comment on the dips that we saw in the proportions, and you said seasonal changes.
Yeah, so we, like I mentioned in the presentation, that we saw some regular dips in the plots in the use of remote consultation. What we observed was that there was no reduction in the use of remote consultation during those periods. Rather, there were more kind of appointments data, which were in the denominator for our analysis. So that means that somewhere around those periods, there were increasing face-to-face appointments. We might want to say that might be the period of vaccination for most people, but those are some of our explanations for that, but it's yet to be seen what exactly is responsible for that. But absolutely, as we've seen in our data, it's also in the NHS digital data, which is publicly available.
Yeah. And actually, there's another question just popped in here, a note, and that's quite interesting observation about the low level of appointments, consultations were very low in 85+ group and was consistent across the graph. And the question has been asked, is that for people who are at home, or do we differentiate between community dwelling at home and those in residential care?
We did not really analyze the residential status of the population, but our analysis, we sort of have examined all the consultation records that we have for this group, but we can plausibly say that the reason for that is because of the size of the group itself, and that might have been been responsible for the number of consultations and total appointments seen from the analysis.
The total number of people in the 85 group is considerably smaller than the total number of people in 18s to 49s, so you're going to have smaller numbers. Nonetheless, of course, when we look at the proportions, the 85+ was the highest proportion pre-pandemic, which slightly surprised us. But we think probably does relate to consultations remotely from care homes and with proxies making those consultations. Although we can't tell from the data at this point. I'm sorry, I'm answering the question for you.
Thank you, Chris. Yeah, I was going to say that as well, but yeah, absolutely, because we can't answer that from the data. We were at the OPs to take this forward and do further investigation.
Okay. I've been asked if there is opportunity to do something at ward level. So we mean ward as in geographic area rather than hospital ward. Is that something to consider? I think, is that something we would be able to consider in the future?
Yeah, absolutely. The Open Safely platform provides data for MSOA, so it is very likely that might be possible. But yeah, like you said, Chris, we might consider that for future analysis on the project.
Our problem once we get down to ward level analyses is it gets very close to almost identifiable data because of the numbers of people involved, and so one would have to back off doing such an analysis if there were very small numbers. Okay, thank you very much for your questions. I'm going to go back to the question that was asked for Alex because we failed to ask him earlier on. And that was a question about whether and why hospital services were excluded from the review. And I think it might just have been the way you expressed something.
Yeah, thank you. Yeah, that was just poorly explained on my part. So what I meant was we excluded work that had just looked inside hospitals. So if there had been a change in the way of working within a hospital, we would not be interested in that. But yes, we were interested in use of technology to connect people from outside the hospital into the hospital. So things like outpatient, hospital at home, etc., virtual appointments. Yes, we were interested in those. Sorry, that was just yeah, poorly explained on my part. Thank you.
A lot to say, a lot to present, and trying to choose just a few words to say it sometimes. Yeah. Okay, thank you to everybody who's attended, and thank you very much to our 3 speakers for their brilliant descriptions of the work that we've been doing, and thank you to the whole team that's been involved in setting this webinar up and doing the work that has been presented. So thank you very much to all of them. Thank you to all of you for attending today. I have to point out that any of the questions that have been posed, which we haven't managed to answer, will be put into a sort of feedback information that will be made available at a later date in the next few days, week, and they will be sent out along with a link to the video. Our next webinar is on caring as a social determinant of health, and is looking at who experiences the greatest impact and what works to support carers. And that will take place at midday to 1 o'clock on Wednesday, the 12th of June. And if you are interested, please make sure that you register via our events page in the same way as you are registered for this one. Obviously, any problems, just pop us an email to our email address and we'll be able to help point you in the right direction. So next one is 12th of June, 12 o'clock on carers. Thanks to all our speakers. Thanks very much for coming, and cheerio. Bye-bye.